Hi, my name is Paul Holmes. I'm a paediatric intensivist here in Brisbane and director of the Children's Retrieval Service. I'd like to thank WIFPICS for giving us this opportunity to represent Oceania. I'm going to talk today about some of the unique challenges we face here in Queensland, even just getting patients to intensive care units. I'd like to begin by acknowledging the Aboriginal peoples and Torres Strait Islander peoples as the First Nations peoples and traditional and cultural custodians of the lands we work upon to support the provision of safe and quality health services, and pay my respects to elders past, present and emerging. The Aboriginal people have lived on this land for 65,000 years and are the oldest living culture in the world. Torres Strait Islanders settled here around 4,000 years ago, and currently 63% of their population live in Queensland. Almost 5% of the Queensland population identifies as either Aboriginal and/or Torres Strait Islander origin, and 7% of Queensland children do too. Almost half of Indigenous Queenslanders are under the age of 20 years, and there's a greater proportion living in rural, remote, and very remote areas, which presents its own challenges. Looking at the geography of Queensland, it represents almost a quarter of the Australian continental landmass, coming in at 1.7 million square kilometres. There are over 5 million people living here, and 1 million of which are children. They live in major cities, regional centres, remote and very remote areas. As you can see, this is a very skewed distribution, mostly towards the coast and in particular to the southeast, which accounts for 70% of the total population. Distance, therefore, is a key challenge, and driving from Brisbane to Cairns is the equivalent of driving from my hometown of Manchester to Florence in Italy. We frequently are faced with challenges due to the weather. There's an annual storm season, we have cyclones, and often have to deal with flooding. As the case a bit later will illustrate, we have limited resources, in particular the number of retrieval assets it's possible to have, and also the facilities at the local healthcare clinics or hospitals who are referring to us in the more remote regions. We also want to maintain cultural safety and have challenges with sometimes crossing borders in the era of COVID. Queensland's been relatively unaffected by COVID, off and on. But when we have to cross the border, depending on the activity in the other state, it can cause problems and mean a whole bunch of paperwork needs to be done before the retrieval gets off the ground, literally. Coordination of retrievals is undertaken from a central agency in Queensland called Retrieval Services Queensland. These are the paediatric and neonatal teams, and they tend to be associated with the intensive care units throughout Queensland. There's also the ambulance service and a couple of aeromedical teams staffed by whole-of-life clinicians who are based throughout the state, and there's also a handful of other Rotary providers. Just like to give a quick shout out to some of our friends in the other retrieval services throughout Australia and New Zealand. In South East Queensland, we annually coordinate about 2,000 cases from Queensland and northern New South Wales, and our teams retrieve about 800 cases, 10% of which are Aboriginal and/or Torres Strait Islander origin. Half of all our cases are undertaken by road, and the rest are split between rotary and fixed wing assets. The average duration by mode is for road around about 5 or 6 hours. Rotary tends to be between 6 and 8 hours, and the fixed wing between 10 and 12 hours. The longest duration of retrieval we have on record was 30 hours due to various logistic difficulties. And of those we retrieve, our teams retrieve, 2/3 of them end up in a critical care, so intensive care unit, and 1/3 will go to an emergency department, and some are then onto the ward. There's also a handful of retrievals who go interstate, and some that we take to the Children's Hospice Hummingbird House here in Brisbane, and some also go home who are on a palliative pathway. So thanks for listening. That's some of the challenges we face, even getting patients to the intensive care units here in Queensland.
So I'm Anne-Marie Brady. I'm the clinical nurse consultant for Checkers, the Children's Health Queensland Retrieval service. And we have a very busy service, as Paul spoke to, but obviously providing family-centred care is a really important consideration for us. Often these families are meeting us on what they would consider to be the worst day of their life. So having family involvement is very important to us. Having said that, there are some limitations. We know that approximately 50% of the time we can't transport family members or caregivers with us, and that's quite a significant number when you think about the number of children and the geography of the state that we're transporting within. And there's lots of reasons for that. Some of those, as Paul spoke to, are about asset limitation. So we always involve parents, caregivers in any decision making that we make. We always advocate for them to travel with us where possible. It's especially important for the family and for the team and the children, given the distances that we travel, that they do accompany us. And often because of the severity of illness of the children, it's really important that we can have family members accompany us. As I said, we do try to involve family members and caregivers in decision-making around transporting the children. And this is particularly important in those transfers or retrievals that we do where there's end of life or returning to home, and also those interstate ones. We do go to Darwin, Melbourne, and they're often quite long and complex retrievals. So we do try to provide as much family-centred care as possible. In terms of the Aboriginal and Torres Strait Islander children and families that we transport, we make sure that we involve the Indigenous liaison family officers as soon as possible, and they've often made good contact with the Indigenous liaison officers at the receiving hospital. And we always try to practice our retrievals in a culturally safe manner as well. That's very important to us. And also for the linguistically diverse families, we try to accommodate those requirements, and that may be something as simple as having translators on our retrieval phones, and we also involve interpreters where possible. We're also working with other resources for hearing impaired families as well, because it's very important to them that we involve those in whatever way we can in any decisions and transfer of information as well.
So hello everyone, my name is Florian Pratcher. I'm a PICU consultant and a retrieval specialist in Townsville, North Queensland. And I just want to cover a few more details following on from Paul's general overview of the retrieval system in Queensland. So we here in North Queensland have a unique situation based on distances and the population that we serve. We have a very high percentage of Indigenous and Torres Strait Islander children that we retrieve. That's more than half of the children we retrieve. Distances are very, very significant. There are some examples here. So if we go to Thursday Island from Townsville, that's just over 1,000 kilometers from Cairns to Brisbane, 1,700 kilometers. And that results in a general average one-way retrieval distance for our retrievers of 380 kilometers and an average time of 7 hours. Just to illustrate some of the challenges that we face here on a regular basis, we've selected one case to go through. So this case was a 2-week-old child that had been dropped off by the parents at Arakan Health Clinic, and essentially at that point, floppy and blue. This was the pre-call information we got. The treatment that the child had received at this point was a fluid bolus of 20 mL per kilo of normal saline. It had received some dextrose for hypoglycemia via an intraosseous, which then subsequently tissued, and a second attempt was on way. When we got on to the clinic to do a quick assessment of the situation, the child was breathing, had a patent airway, but had significantly increased respiratory effort and received intermittent back valve mask assisted breaths of oxygen. The saturation was in the low 80s and with oxygen acceptable above 95. Child was tachycardic and shocked with markedly prolonged capillary refill times. Blood pressure was unable to be recorded, which was a technical issue as well, because there was no appropriately sized cuff available. Femoral pulses could be palpated. Child was drowsy as expected and irritable with now a normal blood sugar. We activated our team wanting to retrieve this child as soon as possible at 15:20, and were then subsequently informed by the retrieval services that an aircraft would not be available because the local aircraft was non-operational because of a sick pilot. So because of that, aircraft had to come from Cairns to pick our team up and go up to Arakun with an expected pickup time of 1900 at the airport. And we send our team out of the hospital at an appropriate time to meet the aircraft at 1900. When we got an update, just as our team was leaving on the child's condition, the child still had a very irregular breathing pattern and received relatively irregular BVM support. Intubation was not an option because there was no doctor with airway skills on site, and also X-ray facilities weren't available. From a perfusion cardiovascular point, there wasn't a significant change, no marked improvement, no deterioration. IO remained in situ, and the dose of cefotaxime had been given. Child remained flat and only cried, responded to procedures or cares. Our team finally landed at 23:30 in Arakun, and then discovered that our stretcher did not fit the local clinic ambulance. The clinic had sent a troopy out to the airport, which unfortunately wasn't compatible with our stretcher. So eventually a solution was devised where the stretcher was loaded on the back of a ute for transfer from the airport to the clinic, and our team eventually arrived. When they arrived in the clinic, the child was now at this stage spontaneously breathing with a regular pattern and had a Hudson mask on, running in 8 liters of oxygen per minute, and that gave the child sets of just 92. Heart rate and blood pressure were now normal on assessment by the team, with still delayed cap refill time and probably not perfect perfusion. Child remained drowsy, but the team was comfortable to just manage with high flow, inserted an intravenous cannula, and then essentially prepared to move back to Townsville. The return journey was interesting, as in now the child was on the stretcher and needed to be loaded with the stretcher into the back of the ute to be transferred to the airport, was eventually arriving at the airport, taken on the plane and flown back to Townsville, where the child arrived at 4:30 in PICU after essentially a very, very long time. The diagnosis was bronchiolitis, and the length of stay in PICU after this endeavor to get the child to us was less than 24 hours. So in this case, we selected to essentially demonstrate the challenges that we face on some of our retrievals just based on the environment that we operate in. So in this situation, we had 8 hours before our team was making patient contact to assess plus minus manage, and we had a total retrieval time of 13 hours. And that was mostly because of the logistical challenges that we faced with an unavailable aircraft due to a sick pilot initially. We then had significant issues getting our equipment, team and stretcher to the clinic, needing to use a ute, which is probably not a perfect solution. We were unable to instigate the management that we would have normally wanted before our team arrived because of the skill set and the equipment available at the health center. And luckily in this situation, the weather was not a barrier to the retrieval, despite the fact that this case was referred during the wet season. Yeah, so I hope that presentation helps to understand some of the challenges that we face here in North Queensland, and thank you for your time.
I'm Ali Ferguson. I'm an advanced physiotherapist in paediatric intensive care at the Queensland Children's Hospital. I'm going to talk to you today about cultural changes that we've had in PICU, and this relates to changes in practice in our unit. So in Australia and New Zealand, the mortality in PICU is now below 3%. So that has really led to a shift in the focus of our care, because we're starting to look at the long-term survivorship of patients and how they are left at the end of their intensive care stay. What we do realise, due to research that has been happening around the world, is that the PICU-acquired comorbidities are increasing and the complexity of our patients are increasing. Where once the focus was on resuscitating the child, stabilising the child and optimising their treatment before even considering rehabilitation, now we are looking at a new paradigm of incorporating rehabilitation throughout their admission from the start of their PICU admission. We know that the impacts of critical care comorbidities relate to sedation, delirium and immobility. And these can have short and long-term effects on the patient. We know that they can have experienced decreased physical functioning, cognitive decline, psychological stress, reduced quality of life, and we know that that can really impact on child development and on long-term quality of life for the patient. So that really led us to looking at how we could help try and prevent some of these comorbidities from developing in the paediatric intensive care unit. At Queensland Children's Hospital, we decided to implement the evidence-based Society of Critical Care Medicine's bundled strategy called PICU Liberation, and we've put our own slant on that. We've got an interdisciplinary approach with medical, nursing and allied health involvement. And this really involved a number of years of planning. And before we implemented, we needed to educate staff and look at how we were going to help staff to feel safe with a change of culture. We really realised that the safety and quality were vital for uptake by the staff. So the bundled approach is on the right side of the screen. It's the A to H. And the ICU Liberation Collaborative, which was started by the Society of Critical Care Medicine, was first implemented in adults and has really good evidence. So in terms of PICU liberation, we established daily goals within the medical ward round, and we frequently use outcome measures relating to pain, agitation, sedation, delirium, withdrawal, and physical assessment. This is followed up each day by a daily check-in in the afternoon, where a nurse and allied health or medical staff goes bed to bed and works with the bedside staff as to how they are progressing towards their goals for the day. We've found this has really empowered the nursing staff to and has made their outcome measures much more meaningful, so that they are able to target their therapies to help meet those goals for each patient for the day. Our aim is to have a more awake, mobile patient. It's important that we optimise analgesia first. We're aiming for slight sedation wherever possible and minimising the use of benzodiazepines. But what we've really tried to do is increase the use of non-pharmacological cares. And what I mean by that is optimising the environment, making a clear day and night cycle, engaging the family and the caregivers at the bedside in the patient's care. Part of PICU liberation involves early mobilisation. Where once our patients were immobile and deemed too sick to move, we're now utilising an evidence-based early mobilisation program with an Australian slant. So we have tiered activity levels, a koala, a wombat, a kangaroo, and we utilise road signs at the bedside on the patient's doorways so that there's visual cues for all staff to know where that patient is for that day and the mobility expectations for that day. All children in PICU are eligible, who've been in PICU for over 24 hours are eligible to participate in the program. And if there are contraindications to the child being mobile, then they are classified as a lizard. We also utilise the Children's Chelsea Critical Care Physical Assessment Score as an objective measure. This score was adapted from the Chelsea Adult Score at the Queensland Children's Hospital in 2018. We aim for 3 activities per day and are empowering nursing staff to lead that, supported by allied health staff. At Queensland Children's Hospital, as part of Liberation, we have done a special rollout for the infants who are less than 6 months old, as we identify that they are at higher risk. We acknowledge that they have specific needs, and this baby liberation package is really based on the NIDCAP principles, so individualised developmental care and assessment for these babies. This is unique to Queensland Children's Hospital Liberation, but is based on all the NICU work and the first 1,000 days principles. It applies across every liberation element. So things like involving the parents in the baby's care, minimising bright lights and noises, involving the families in nappy changes, having positive touch by families or carers or nurses, and also nesting the children in a developmentally supportive position. The H element in the PICU liberation is humanism. This has been really a wonderful part of implementing PICU liberation because it's encouraged staff within PICU to get to know our patients. Patients now in each bed space have photos, family photos up on the walls, and we're really encouraging the families and carers to show us the child that was pre-PICU and to try and de-intensify the environment. We work on a really family-centred care principles, and as you can see in the picture there, that child is having time out on the mat being read to by a nurse, and that is something that previously probably wouldn't have happened. And now, as nursing staff and allied health staff are becoming more and more familiar with mobilising children and having children more awake, these are really nice things to start and see as people become more comfortable and feel safer. We really dream big here at QCH. We are adopting things like Santa photos and celebrating patient birthdays. We had an elf on the shelf who would appear in various places in PICU and children could mobilise to. We're acknowledging children's bravery and providing them with beads. We're trying to de-intensify the environment and do things like messy food play. I think this is really helping the staff morale in PICU and showing families and staff in PICU that we can celebrate these milestones and these times, even though their child is in the intensive care unit and their family is under a time of stress. Implementing PICU liberation in our unit has made a really big difference to how staff feel about having more awake patients and having more mobile patients. And we've certainly found the longer that we have implemented PICU liberation, the more comfortable staff feel with having more awake patients and mobilising patients that we previously hadn't. This has been a great change for our unit.
Hello, everyone. As part of cultural change, we have started with well-being initiative in our PICU, and we utilize mindfulness-based program for that. I am Rahul Joshi. I'm one of the pediatric intensivists. I'm working at the Queensland Children's Hospital as well as Gold Coast University Hospital. So we know that in our healthcare environment, especially in ICU, we have to work efficiently, effectively at our highest physical, emotional, and psychological level. We always talk about patient outcome, but we tend to ignore about our colleagues and our staff. We work with them for so many years. With the stress at work, we tend to carry that stress home. We come across a lot of ethical issues looking after patients with lowest mortality. The morbidity of patients have been increasing over a period of time, and that leads to emotional exhaustion. The work we do here in ICU, sometimes we take that home and we think about that. That affects our social life, affects our family life, and can lead to burnout. It subsequently have issues with relationship, progressing through our professional career, and also financial insecurity. There are multiple studies which have shown that the ICU staff, especially in developed countries as well as developing countries, they are at significant risk of burnout. The study with emergency doctors, they showed that the burnout percentage is quite high, 70% compared to other subspecialties, which is around 45%. And nowadays, this is where we are with maximum stress and minimum, happiness. We know that in acute stressful environment, like looking after patients, these situations are manageable. But if we come across ongoing, persistent, chronic stress, it's not good for us. It leads us to bad habits, poor sleep, improper diet, substance use, and our life is out of balance. We know that there are various definitions about burnout. This is the one which showed that it's a complex physiological and psychological state, and it leads to a experience or response to prolonged exposure to stress. What happens, as I already mentioned, that it leads to emotional exhaustion and depersonalization. There were a study done recently where staff have been questioned, and they said that if they have a burnout, then there is suboptimal patient care, the performance is reduced, the sick leave is more, and there is a high turnover of staff, leading to reduced quality of care, more inputs into training new staff. The nursing survey, which involved nearly 900 patients, 900 nurses, which showed that the burnout is associated with poor general health and increased work stress, adding to the economical cost to the society and to the country. We, as an evolution, we have evolved from just having, resting, eating, and growing to doing high functioning activities. And the peaceful nerve, vagus nerve, parasympathetic nerve, which we are not utilizing as much as required. We tend to have this practice of having, a normal, gentle nasal breathing, sighing, yawning, laughing, sobbing, spending time with the community, and that's not happening that much. And with added COVID and the restrictions, wearing mask at work, it's getting quite tough. So vagus nerve, how can we activate vagus nerve? By using ocean breaths or victory breaths or ujjayi breaths. So it's like an ocean noise when we breathe out, and we do it with mouth closed. What it does is it stimulates GABA, it produces GABA, and what GABA does is antidepressant. So more we do a slow, gentle breath, more GABA is produced, and we feel happier. This just another example where we have, when we breathe normally at a minimal rate of 12 to 15 breaths per minute, nasal breathing, we have some heart rate variability. But if we breathe faster in stress, with anxiety, there's no heart rate variability. What happens if we are hyperventilating? There's not enough cerebral perfusion because of vasoconstriction. So with this stress, with these challenges, why do we work in ICU environment? Because we like the work, it's rewarding. But we just have to remember that it's not making us, we are not taking what we are doing at work to home and affecting our family life. So how can we improve that? By self-reflection, being aware about what we do, doing what we enjoy, having some strategies and coping mechanism, talking to a friend. There are US organizations, and what they have said that there should be a well-being and resilience program in each institute. What it does is it helps us with our emotional stability and building resilience. So we need an institutional approach as well as a personal approach. This personal approach is at our individual level, but the institutional approach will change the system. So we decided to have a workplace program that addresses the coping with stress and reduction in illness. So we utilize mindfulness-based program because we know that it's good for self-awareness. It improves focus and memory, and it can slow down our heart rate, blood pressure, and help with our anxiety. It's not for everyone, but I think everyone should try and see what's right for them. Some will enjoy spending time in the community, sports, activities, swimming, just having something different to what we do at work. Studies have shown that if we are mindful, their patients can sense that. They have increased feeling of trust. They've showed that there is increased safety as well as more sense of being understood and cared for. As we know that we either think about future or past, but we are not in the present moment. If you ask a child, they think about at that time, at that moment. So we need to come to a present moment, and how we do that with paying deliberate attention in a non-judgment, acceptance, and awareness. Accept people as they are. That will help us progressing forward. So what we decided is to implement this program and see whether it makes any difference with burnout, depression, or anxiety. Encourage staff to do a practice every day if possible, and see whether that helps with the medical decision-making, engagement, job performance. And ultimately, it all will add to quality and safety of the health system. The meta-analysis done by Gilmartin showed that a brief mindfulness-based program in hospital settings showed positive change in the participants' well-being. Another study with mindfulness meditation program and a regular practice have reduced impact of stress, depression, anxiety, burnout, and the staff turnover is reduced as well. So what we did here, we started this program 6 months ago. The idea was as a pilot study to see if it is feasible in this work environment, can we coordinate, and whether it can be utilized. Doing a survey to see self-reported mental well-being and is there any improvement with the work environment. We also want to see the impact of the regular practice and whether how the staff find it doing it at work and their ongoing desire to continue the program. So we did a survey less than 5-minute survey in August, and a follow-up survey just last month. And we're doing 20 minutes group practice, which consists of some gentle movements, some breathing, and mindfulness meditation. I'm utilizing various practices like a body scan meditation. So we did the demographics of the staff, 14 items, mental well-being scale, and the work environment scale, and then assess their practice, how easy they find the mindfulness practice. So we had 220 participants with various professional background, a different age group, and experience in PICU. What we found that 1 in 5 have concern of their mental well-being. When we assessed the work environment, 1 in 4 were nervous coming to work. 1 in 4, they found that they have excessive workload, and nearly 16% their reported survey showed that they have some conflicts at work. The mindfulness practice was not much at that time, and but nearly half of the staff were interested in continuing mindfulness and having this program at work. We followed up for last 6 months. We had total 210 plus. There's another program happening now, but 210 plus participants with admin staff, allied health, pharmacy, medical staff, nursing staff attending the session. We did another follow-up survey, a nearly similar number. We haven't analyzed that as yet, but the response is quite encouraging. We have some mindfulness posters around the blood gas machine, which just have it to have some breaths in between while waiting for the gas results. We also have some posters in the tea room about just being in the present moment. And we are hoping that we continue this program and expand it across another institutes and other hospitals across Australasia. Thank you.
Right, thanks, Raul. My name's Paula Lister, and I'm a paediatric intensivist here in Queensland in Australia. And I just wanted to say thank you to WIFPICS for inviting us to share our experiences in Oceania. It's really very exciting. So I've been asked to give some reflections on what I think the future directions of paediatric critical care is in terms of team working, and then my colleague Debbie Long will be talking about research in that area, not team working, but in longer term PICU outcomes. So interestingly, I was asked whether we think we're moving from multidisciplinary team working to interdisciplinary team working, and I kind of just as a reminder to the audience that multidisciplinary team working is where lots of disciplines come to provide care to a patient, but they don't necessarily interact. They still tend to work in their own silos. Whereas the interdisciplinary team working, there is much more communication and shared learning and sharing of ideas between team members so that they're able to deliver sort of a more integrated product for their patients. And I think, having worked both here and in the UK in the last 5 years, that the majority of my consultant life has been in an interdisciplinary team working environment, and it's becoming increasingly so. And I think if you just have to listen to Ali, listen to Paul and Anne-Marie, listen to Rahul, you can see that that's where we've moved in paediatric intensive care. And I think that is reflected as well in how we educate ourselves as a team. We share a lot of education opportunities, both in terms of higher education, whether it's PhDs or masters, and indeed in continuing professional development. But it's also really reflected in our research program. So you may have a research program around either congenital cardiac heart disease or around neuroscience in children, and you'll find that many disciplines come together, sharing information, working together to provide that program of research to answer sort of tricky questions. So I think we've been working this way already. I don't believe this is the future. I think this is our current working environment. But I do think there is a change coming, and I think the change is more about moving. We tend to do this interdisciplinary team working within our units, and we are starting to move outside of our units when we think about stroke protocols or, you know, just-in-time types of care. But we do tend to keep it more or less within our facility or within our units. And I think when you think about working in Australia and the unique perspectives that Paul and Anne-Marie have given us about the population spread and the geographical distances in places like Queensland, I think we can see that you need an awful lot of collaboration, cooperation between colleagues in order to provide care, particularly critical care to children in such a vast area. And I think that is fostering a new paradigm for us beyond that really goes beyond the interdisciplinary working. And it's what's commonly being termed in other industries as transdisciplinary working. So you can see that as you go from multi to inter to trans, that there's increasing integration of the different disciplines in coming together to provide that care and to provide that outcome. And there's increasing inclusivity of different perspectives. And I think particularly for us in pediatrics, it's involving parents and families, not just as the end users, but actually involving them in the delivery of the care because they are the experts in their children. And our goals are becoming increasingly more whole of problem orientated rather than just the task at hand. So we're tending to look far more at a whole journey for the patient or their experience through their illness and sickness. And I think that's quite it's a lovely concept that's coming to fruition. And I actually just wanted to share my role as a lead in our Queensland Paediatric Sepsis project, just to illustrate some of those key features which have been a huge learning experience for me. So we sat in our PICUs and we found that we were getting a lot of kids with sepsis that seemed to be being recognised late. Our lovely Patient Safety and Quality Council undertook a review of severe adverse events of children, and they found that there was an inordinate number of those actually presented with sepsis, and of those children who presented with sepsis, not hugely unsurprisingly, there was an overrepresentation of children who were in remote geographical areas. There was certainly a vulnerability amongst the First Nations children. And when they dug down into what the reasons were for these adverse events, not surprisingly, it was an under-recognition of sepsis. It was delayed diagnosis or even misdiagnosis. And what was not represented on there is as a failure to listen to parents' concerns. Those were key features. So understanding that to be the problem, we set up a project and thought this is easy to solve. 70% of kids with sepsis come in through the EDs. So let's target the EDs, let's improve recognition and treatment. Fairly easy task, and we'll achieve our goal, which was to reduce the variation in care across the state, but also to reduce sepsis ICU and hospital lengths of stay. So obviously mortality is not an easy endpoint for children because our mortality rates are low anyway, but we could make a difference in perhaps reducing lengths of stay. And so we set up a project team, and we started pulling in various disciplines and lots of different people from across the state. And importantly, we really involved our consumers and ended up having a co-design solution to this. We were tackling different elements of the project, particularly around supplying decision support tools. So you see that as a sepsis pathway that people could use. We were particularly concerned around what support parents needed, and so we developed some information leaflets and information media for parents. We found that education was a key element, and the education we've understood was not just one discipline, so we had to pull in an interdisciplinary team there, pharmacists included, physios, nursing, medical, and so we pulled in an interdisciplinary team there. And then we thought, well, we need to performance monitor how facilities were doing. We need to feed that back, and we were very keen to look at balancing measures that we weren't causing harm by introducing these pathways by overuse of antibiotics. And obviously we then needed to analyze the project. So it seemed quite a simple brief, but as we got into it, so we got more advice from all of these as the disciplines merged, and we started to share ideas and have a joint outcome. We started to realize we were being oversimplistic in our viewpoints. And really what we should be looking at is right from the beginning, children are arriving into hospital all the way through to getting them home, and that our goal probably of just reducing hospital stay wasn't enough. We actually need to be thinking about getting a child integrated back into their community, into their family, into their school, and hopefully with higher numbers of survivors and fewer numbers of children with permanent deficits. So our goals really had to change. And thinking about that, our team had to change. And we now have a similar goal altogether with a huge variation of team members, ranging from clinicians from varied disciplines, whether it's pediatrics, ID, general pediatric intensivists, as well as different professional standings, whether they're nursing, doctors, pharmacists. We have data scientists, we have epidemiologists, we have a huge range of people who are coming together to deliver and sharing across our disciplines to deliver this single project. So it's been an incredibly enlightening project for me, and that this is the way I think the future is for PICU. I think we need to be embedded in our community and not just the icing on the top when things get bad. I think we need to be embedded in our community so that we can deliver that service in a transdisciplinary way. And I think there are a number of projects that are moving in that direction. And just to give you an idea, this is my wonderful team full of huge numbers of people who are working and collaborating together to deliver it. And I think that's our future. Thanks, that's all for me.
Hi, my name's Debbie Long, and I'm a PICU nurse and clinical researcher based at the Queensland University of Technology and the Queensland Children's Hospital. Today I'm going to be talking about the research that we're currently undertaking in the region, specifically the work that we're doing with the Australian and New Zealand Intensive Care Society Paediatric Study Group. And this is an organisation that has evolved over the last 20 maybe years, where it was predominantly just medical representatives from each of the tertiary level PICUs driving any research that was being undertaken, to now really evolving as a group. And some of the things that have really evolved in that is this interdisciplinary research, and now, as Paula mentioned, moving to transdisciplinary research and collaboration. And that's not just collaboration across all of our PICUs in Australia and New Zealand, but that's also collaboration with our international partners as well. As both Paul and Paula have alluded to, is the vast geographical distances between our centres in Australia and New Zealand, and also our small number of participating centres, means that we really need to all band together and work to a common goal and have all of our units participate in this research. So that's an area that we're really moving towards and focusing on. The other things that have changed within our research group is that we have developed several committees or subgroups that have been focusing on a few key areas. And what we're now seeing is that these key areas coming through in each of our studies that we're conducting, and they're specifically around education, early career support, long-term outcomes, consumer engagement, and data science. One of the things I wanted to mention about today is the the priorities that we've researched over the last 12 to 18 months of research priorities in Australia and New Zealand. And we undertook a modified Delphi process of just under 200 nurses and doctors. A limitation of this study is that we didn't have consumers in this, and this would be our next step, particularly as part of our consumer engagement subcommittee. And we asked clinicians to comment on some priorities around topics and questions for research, but also on outcomes in terms of what was feasible and what was important. So I'll just briefly talk about those. The two most prioritised topics or questions were in the broad area of intravenous fluids in resuscitation and also patient and family-centred outcomes. So you'll see that moving forward, a lot of our studies are now focusing on these areas in the first instance. In terms of outcomes of measurement, obviously, in terms of the feasibility for all our units to collect information was more around mortality, length of stay, and organ support and organ dysfunction, which was different to what the clinicians ranked as the most important outcomes to measure, and that was more extending beyond the walls of PICU into quality of life and neurodevelopment. And specifically when we looked at our top 20 outcomes, it was a combination of what was feasible and what was important. So these are just individually listed as what's feasible, what were the most feasible and what were the most important. And then if we have a look at our top 20 outcomes and priorities for research, you'll see that mortality and PICU length of stay as a combination of importance and feasibility are their top ranking outcomes. But in there, we also see quality of life, survival-free days, survival greater than 12 months, mortality, long-term mortality, and also dependence on medical technology at discharge. So we're really seeing the very acute care outcomes that we have previously looked at and are very feasible and easy to measure, but now seeing the rise of outcomes which acknowledge true patient-centered care. And you know, this has been a real paradigm shift in intensive care medicine in general, where we're seeing a reduction in mortality and a rise in new morbidities. And the lower our mortality rates get, the harder it is to use that as a primary outcome. In terms of our current projects that are currently happening around Australia and New Zealand, we have 4 big pieces of work that are occurring. So the NITRIC study is an NH and MRC funded trial of 1,320 children. It's in Australia and New Zealand, but we also have a site recruiting in the Netherlands. And this trial is almost finished. We're only about 20 patients away from completing this. And this has been a huge achievement for our PSG group. The NITRIC study is a 2-armed randomized controlled trial looking at the use of nitric oxide during cardiopulmonary bypass and open heart surgery in infants under 2 years of age. And the primary outcome for this study is length of ventilation, and some secondary outcomes we're looking at a reduction in low cardiac output state, ECLS, death, and also some neurodevelopmental outcomes. So we look forward to sharing that with everyone once the data's finished cleaning and monitoring, and we've got some results to present. Following on from the NITRIC study, we have been successful with some further funding, which is now following up these children from the NITRIC RCT just in Australia and New Zealand annually until their 5th birthday. So these children were under 2 when they were recruited. So some children will receive up to 4 or 5 assessments every year until their 5th birthday. And obviously 5 years is an important milestone because that's a time when we're starting to enter school. So we can look at assessments that cover both the child and the family and school readiness. And the assessments that we're using annually are completed online, and at their 5th birthday is a full face-to-face assessment. And these are based around the domains identified in the PICS-P framework. In addition to this, we've had a pilot version of the Respond trial running, which is an Australian and New Zealand study of 60 children, and that is also almost complete. And this will go to a full trial shortly of 680 children around Australia and New Zealand. And this will be a 3-armed RCT of metabolic resuscitation. The primary outcome is around PICU-free survival, and some of the other outcomes are around free of organ support or organ dysfunction, free of ventilation, obviously mortality, hospital length of stay, but also we're looking at quite a few neurodevelopmental quality of life and parent outcomes as well at 6 months. The fourth study we have running in the PSG is the Thrive study, which is a large NH and MRC funded study of 960 children in a 2-arm RCT of high flow in emergency intubations. And this study has been conducted not just in PICU, but also in the NICUs and in the ED. It started out as just in Australia and New Zealand, but we are now reaching out and collaborating with Canada and Switzerland. And I believe that we have other international sites coming on board shortly. The primary outcomes for this study are around a patient-centered outcome and also a operator or user-centered outcome. So hypoxic events and also successful first attempts. In addition to these 4 major studies occurring within the PSG, we often always have smaller studies undergoing work at the same time around surveys and audits of clinical practice and treatments and epidemiology with data linkages to our PSG Australia and New Zealand PICU registry. So I mentioned that we had some future projects on the cards, and these are really now starting to reflect the areas that were identified or the topics identified in our research prioritisation modified Delphi. And these ones are really sort of tapping into where Paula was talking about in the transdisciplinary space, and really engaging and co-designing with consumers and other key stakeholders in that area. So, and none of these are confirmed yet, but they're things that we're very much looking forward to starting, pending grant applications and collaboration with other sites. So the gastric studies based off a huge amount of work by Levon Toom in the UK, and it's an NHS and NH and MRC targeted grant looking at gastric residual volume versus no gastric residual volume in the PICU. And so, as I mentioned, it's a nurse-led study that's a collaboration with the UK. And the primary outcome, it's a co-primary outcome of length of ventilation and reaching caloric requirements. And we're very much looking forward to this collaboration. It's the first time we'll be doing a big study with the UK. Shared care for long-term follow-up, as I mentioned, is a really sort of transdisciplinary co-design project looking at RCT of GP shared care, so that's general practitioner or family practitioner shared care for the early screening and targeted intervention and follow-up for children post-critical illness. And we're looking, we've got consumers and GPs and early childhood educators working on this project. And as Paula and Paul mentioned, with the geographical dispersity of Australia, we really need to have a system solution for following up our children. It's very difficult to move children around the states to have face-to-face follow-up all the time. So we're looking at moving children back into their home communities. So again, as Paula mentioned, it's looking at the whole problem, not just the icing on the top or the immediate problem at hand. Another project with huge collaboration is the Prompt Bolus study, which is a NIH-funded study. So it will have large collaboration with the United States. And it is a randomized control trial looking at balance versus normal saline in a sepsis cohort. And then finally, a little bit more locally is the reduced trial, which is looking at restrictive fluid strategy. So again, we really look forward to sharing with you some of the outcomes of our current studies, which are about to be finalised, but also sharing some of the systems and processes that we're learning along the way of setting up some of our future projects. Thank you.
Neighbours, everybody needs good neighbours. Just a friendly wave each morning helps to make a better day.